Okay, so good afternoon, everybody. Tere päevast. Aitäh kõigile tulemast. So we are having today two guests from the United States, Nona Kiknadze, who is a doctoral student in counselling psychology, and it's University of Miami. And then we have also Dylan Bailey, who is postdoctoral research fellow at the Department of Religious Studies, and it's University of South Florida. So you have had a long way to come here, and we are very, very glad that you made it. And this talk is taking place in the philosophy colloquium of our department, organized together with the Department of Philosophy and Center for Ethics, but it is also in relation to the Susimetsa residency program, where you are going to start tomorrow. So you do not even know what is going to happen there, but the spring is coming to Susimetsa, and Professor Dr. Theda Rehbock, who was also a guest professor at Tartu for many times, has created this foundation and this house Philosophicum there. And this year we are glad to have 20 residents from all over the world. And you will have also that time to work on your project mental pain, stigmatization, and assisted suicide. And this will be a transdisciplinary approach. But your talk today is going to be about thinking death and suicide in a life worth living, a contextualist approach. And I must say that this is very much related also to the interest of Theda Rehbock, who was a biomedical philosopher, but very interested in life and death issues, and also thought that Susimetsa could be a place where philosophers come to work, but also practice philosophy, that it's a way of living. It's not only to doctorate or to share your thoughts or your arguments, but you also have to live holistically in context or in correspondence to what you actually, what kind of ideas you are sharing. So we are very much looking forward to your talk. Reen Zirkel is going to moderate the discussion, but first you will have the floor. And if you want to introduce yourself in more detail, please do so. Thank you very much for coming. And the floor is yours. Thank you.
Thanks. Yeah, thank you for your time and for coming to our talk. Like Margaret mentioned, I'm a postdoctoral researcher at the University of South Florida. My background is in philosophy, mostly focusing on epistemology, theology, and medical ethics. And a little bit about the background of our paper, then I'll turn it over to Nona to introduce your own background. Yeah, as Margaret mentioned, this is very much like a work in progress. So it's trying to do a lot of things. You recognize that it's kind of exploratory. I'm taking my philosophical background and her background, which we'll tell you about, and providing two different contexts. So it's a pretty contentious argument, but we're going to do some back and forth as we go, and we're looking forward to some pushback. So I'll turn it over to Nona to tell you about her own background.
Hi, everyone. It's wonderful to be here. I am finishing up a PhD in counseling psychology at the University of Miami. And what that means is I actually work as a pediatric psychologist and a therapist. So often in my day-to-day, I'm working in a hospital, I'm working with clients and families, and I'm addressing issues like suicidality and risk. So what we're talking about today is also very pertinent to the day-to-day of a psychologist's work. And so we're going to have some dialogue back and forth between the different disciplinary approaches and ways that we can even deepen or kind of contradict each other sometimes in that approach. So thanks everyone for being here. We're really excited to get started.
Okay, we're going to talk about this more in just a moment, but the general focus of this presentation is that we're going to challenge the universal presumption of moral incapacity in suicidal patients. Nona's going to tell you what that means in just a moment. Very briefly, it's the idea that if someone is either attempting suicide or a suicidal ideation, that they are rationally incapacitated. They do not have a decision to make medical decisions for themselves. We're going to advocate for a contextualist libertarian framework. We're going to oppose this to the dominant view. And our framework we're using, we're going to do a little bit of existential philosophy and psychotherapy. So depending on reading on people like Camus, Nietzsche for the philosophy bit, and Lone and Frankel for the psychotherapy bit, a little Foucauldian critique, and a little Stoicism thrown in for fun. And we're critiquing basically four big problem areas that we see in this presumption of rational incapacity. And this is going to be the structure of our talk. So 4 sections. First is the assumption that suicidal ideation is always epistemically irrational. We're going to argue that there are at least some cases in which it can be rational. Not all cases, but it is at least possible. 2, we're going to critique the over-medicalization and stigmatization of suicidal ideation, arguing that there are at least other types of paradigms that are just as applicable for depressive and suicidal phenomena. 3rd, we're going to critique medical paternalism. We're going to advance an argument for why autonomy is more appropriate in some cases than principle of beneficence, 2 of the main values in biomedical ethics. We're also going to critique the monolithic conception of beneficence. So even if you prioritize beneficence, there are different ways to understand beneficence depending on the context. That's not part of the slide. And then 4th, we're going to critique the qualitative distinction between physical and psychological pain as a justification for suicide and or euthanasia. And with that, I will turn it over to Nona.
So like I shared a little bit in the introduction, I think it's really interesting to compare a philosophical approach here and also understanding the practicalities of what some of these beliefs might kind of indicate in working in a medical situation, right? And so that's the work we're going to do first. I'm going to speak a little bit about what the context looks like within a hospital. Now, take into account, I'm a pediatric psychologist, so let's put the pediatric to the side for a moment. We're not talking about children here, but conceptually, let's think about like rational adults and what this may or may not look like. I'm also going to be speaking from kind of an American setting. We know that healthcare greatly differs, right? Even according to states within a country and then across countries. So what I'm really excited to hear about from all of you is also how this is conceptualized in Estonia. What might this look like? How might it be different or similar? I am operating in a very American context. So we will welcome all that feedback. So like I shared before, there is incredible variation. I'm going to highlight a couple of salient examples in the US context. I am operating in the state of Florida, so we have our own paradigms and our own rules about what this looks like. Let me share a little bit about what this idea of risk looks like from a psychologist's perspective. So our number one priority and how we're trained is that the safety of our clients is paramount. It is incredibly important. As a new psychologist, this is what you learn. You quickly learn how to do something called a risk assessment. You're able to judge if people are a risk to themselves or to others. We can place people on a psychiatric or emergency hold, called different things in different contexts, but the same principle applies. This can be initiated by law enforcement, by medical professionals, or mental health workers. What that means is we put someone in a context in which they do not have the capacity to hurt themselves. They are under supervision, they are controlled. Often this is done in a hospital or some other kind of inpatient setting. Now, we call this different things according to states. In Florida, this is called a Baker Act, right? You use this in extreme situations. This authorizes up to 72 hours of involuntary examination. So someone can do a full risk assessment and you can determine whether or not the person in question is an imminent danger to themselves or to others. Different states may have different rules. So for example, in Texas, this is called emergency detention. It's a 48-hour hold. So the nuances do change, but the overall principle holds. So how do we do this? We conduct a mental status exam for means and intent. What do I mean by means and intent? Means is access. Does a person have access to something to harm themselves? Do they have access to a gun? Do they have access to pills? What are they talking about here? Is that a practical ability to actually conduct these things? And intent, how serious are people? Are these passive thoughts? Are these active thoughts? Are people actually making plans? Do they say they're going to do this tomorrow? Do they no longer have things worth living for? These are all very kind of important paradigms to understand. And this is what a psychologist will do in determining the gravity of a situation. So you are considered to have an emergency medical condition if you are assessed to be a risk to yourself or others. And this medical condition then overrides some ideas of autonomy and independence. So you are presumed to not have decisional capacity. So you no longer have the rights to make decisions for your own healthcare, in a sense, if you are deemed to be a risk. And that's what we're going to unpack here and compare and contrast from different models. After an evaluation, so within that 72-hour, 48-hour, whatever that state period may be, there's 3 options. The person can be released, they can be offered voluntary treatment, or placed under a involuntary inpatient placement. So they may be forced to stay, for example, in a hospital or another mental health facility if they are deemed to be a risk. So thinking about this and the way it's actually put into practice, we're going to explore some different components of these ideas. A couple other relevant medical frameworks here. We have something in the US called the Emergency Medical Treatment and Active Labor Act. This means that everyone has access to emergency services regardless of their ability to pay. And this means the #1 obligation for physicians, especially working in emergency settings, is to stabilize patients. So even if someone has a DNR, a do not resuscitate, but they're coming in for a psychiatric emergency, like a suicide attempt, that suicide attempt overrides the DNR. So the physician has the right to basically make decisions on behalf of that patient because that is considered the top priority, safety. So this is often a decision made by physicians, but often there are crisis intervention teams, mental health professionals embedded in a hospital setting that would be advising on some of these decisions. So we have a quote here we wanted to highlight. Even when a suicide attempt is supported by evidence, such as a history and suicide note, it's customary to provide all means necessary for resuscitation and care on the presumption that the suicide attempt is a result of psychological disorder. Not saying I disagree, but it's an interesting thing to bring up, right? We're going to talk about this idea of medical capacity and decision-making throughout the talk. So 2 main concerns as we start to transition from the medical to the more philosophical here. Mental health concerns take precedence. So if a person is considered suicidal, they're often considered temporarily incapacitated. They're not competent to make life-ending decisions. And again, we're talking about adults here, although we can have a discussion about what this might look like for children, how it might be similar or even different. And there's a medical and a legal duty to preserve life in any healthcare field. This is what we're taught, and this is what the American law supports. So a physician or a mental health professional, they're obligated to intervene to save the life of someone who has attempted suicide, no matter what that person's preference is. These trigger emergency psychiatric evaluations and other legal steps. So not respect for end-of-life directive.
Okay, so this is, thank you for that background, very helpful. And let's see, I don't know how to take this off, but I think it's going up at least. It's optimistic.
It adds a little flair to the presentation.
Anyway, so this is the first of the critiques we're going to make about this model that she just introduced. So we're examining the question of decisional capacity. Is it proper to assume that someone who has attempted suicide or someone who is undergoing suicidal ideation, can we presume that they do not have decisional capacity? Decisional capacity is, in a medical setting, a patient's capacity to consent or refuse care. It requires the ability to understand the relevant information, appreciate the medical situation and its possible consequence, communicate a choice, and engage in rational deliberation about one's own values in relation to the physician's recommendations about treatment options. So is a person a rational agent? Can they understand what's being communicated to them, what choices they have? And lastly, are their choices in line with a stable value system? So if someone has articulated a certain value system their whole life and then they're under care and all of a sudden they're saying something radically different, that's something to consider. This will be very important as we go forward, that consistency in value system. Okay, so Mishari and Weistov identify basically 2 different positions on suicidal rationality. This is a slightly pejorative, I don't love this term, but this is theirs. This is the predominant view and reflects basically what the view that Nona has articulated, which holds that suicide in general is irrational. People who engage in suicidal ideation are being irrational, and sometimes it not always, but it can take an immoral valence as well. In this model, the overriding moral obligation of the physician is to protect life and prevent suicide. So the principle of beneficence, doing good or doing no harm, same thing, is the primary value. And it's generally deontological. informed by content ethics, just very briefly, what that means is, for instance, that there's no utilitarian calculus generally. In some cases, there can be. If there's a shortage of medical equipment, for instance, but generally, what this means is that the value of life is intrinsically valuable, should be stated at all costs, more or less, overgeneralized. The libertarian perspective, the libertarian contextual approach, argues that suicide is potentially rational. So again, not in every case, but it's at least possible for you to attempt or consider suicide and do so in an epistemically rational and responsible way. As opposed to the principle of beneficence, it tends to emphasize the principle of autonomy, which is also a very important principle in bioethics. The freedom of choice of individuals to determine whether to live or die. And it's also contextualist, so deontological is mostly rule-based. Contextualist, just in this context, just means there is no hard and fast rule. It very much depends upon, particularly the situation. And this libertarian approach is a minority tradition in the West, but it does have some philosophical backing. So the existentialists, the Stoics, the Epicureans all had held some sort of version of this. So the Stoic doctrine, the basic idea here is that for the Stoics, the only thing of value is moral virtue. Everything else is literally what they call indifferent. It's neither good nor bad. So there are circumstances in life in which it becomes very difficult to be virtuous. It can be if you are undergoing constant oppression or disease or the loss of all your loved ones, it can be really hard to have achieved the Stoic goal of ataraxia or tranquility. In that case, it's understandable that one would, in one's life, if you're not able to have virtue in those conditions, that virtue is the only thing that has value. It's not preferable, but it's understandable and justifiable. More important than mere survival. And then people like Nietzsche, and I'm going to read a quote from Twilight of the Hours just a moment. Nietzsche and Camus argue that it's not suicide itself, suicidal ideation, that's irrational. In fact, it's the kind of animalistic clinging to life under any circumstances that can be irrational. The idea that no matter how bad your life gets, you never stop to consider, should I continue on? This kind of like biological urge to continue and reproduce at all costs, they think is what is irrational. And they both are going to advocate for a certain kind of like noble death, which is motivated by not a bioethical principle, but a principle nonetheless of existential authenticity. So Nietzsche, this is probably too small for you to see in the back, but Nietzsche offers a really striking encapsulation of the noble death here, and it's kind of a longer quote, but I think it's worth reading in its entirety. He says, "To die proudly when it is no longer possible to live proudly. Death of one's own free choice, death at the proper time, with a clear head and with joyfulness, consummated in the midst of children and witnesses, so that an actual leave-taking is possible, while he who is leaving is still there. Likewise, an actual evaluation of what has been desired, what has been achieved in life, and adding up of life. All of this in contrast to the pitiable and horrible comedy Christianity has made of the hour of death. Only natural death is death for the most contemptible reasons, and unfree death." So he's critiquing what might be taken to be a version of the moralistic death position. Only natural death is death for the most contemptible reasons, and unfree death, a death at the wrong time, empowers death. From the love of life, one ought to desire to die differently from this, freely, consciously, not accidentally, not suddenly overtaken. So he's obviously critiquing his view is sometimes the justification is that a suicide, euthanasia is unnatural, and we should let people's life kind of follow its natural course. He says, no, this clinging to life in any circumstances is unnatural. And turn it over to Tony.
Let me share a little bit more about the medical model and our understanding of disease. So let me talk about mental illness first. This comes from the American Psychiatric Association, one of the kind of governing bodies in the US about mental illness. They define it like this: health conditions involving changes in emotion, thinking, or behavior, or a combination of these. Mental illnesses are associated with distress and or problems functioning in social work or family activities. What does that actually mean? Well, these are the words that are drilled into us as a psychologist, Distress and impairment. You might be familiar with this in other settings. This is how we define a mental disorder, essentially saying that it's causing emotional distress, some other kind of distress. It's impacting a person negatively, and it is impairing function. So when it gets to the point where you can't go to school, you can't see your family, maybe you can't leave the house because of your anxiety, that is functional impairment. So we're seeing not just a subjective, but kind of an objective functional approach to understanding it. And these two paradigms taken together are how we conceptualize mental illness. Granted, we also have diagnostic criteria. I'll go over some of that as well. But thinking broadly, that's kind of the underpinning of this idea of disorder. Well, psychology hasn't always gotten it right. And this can actually lead us astray sometimes. You may or may not be familiar with the history of American psychology. But the DSM, the Diagnostic and Statistical Manual for Mental Disorders, is how we diagnose often in the US. Now, homosexuality was listed as a mental disorder for many, many years. It was originally sociopathic personality disturbance. Then it was retained. This actually goes through revisions about every 10 to 15 years. After that, it was called sexual deviation, finally removed in the next iteration of the DSM. Right? Lack of empirical evidence, growing advocacy, growing protest from communities and professionals that wanted to indicate this is not a disorder. It was seen as a disorder, though, because it went against societal norms. So this idea of what is within kind of the normal curve is problematic in psychology because we pathologize things sometimes that are seen as abnormal, but that also may be a reflection of a cultural value in a certain time and a place. So I think this is one of the most salient examples of the way that this conceptualization can lead us astray sometimes, and the mistakes that psychologists have also made. Let me share a little bit more about explanatory paradigms too. So research has found striking differences in how we conceptualize and diagnose mental illness across the world. Now, I mentioned the DSM is the dominant paradigm in the United States that guides our insurance, our reimbursement. This is what we actually need to basically work with patients if people need a diagnosis. We have the ICD internationally, the International Classification of Disease. More often used in different settings. I would not be surprised if that was one of the dominant paradigms here in Estonia. But research shows that there is great variety in the way these two approaches conceptualize mental illness. So there's not even agreement in modern times in the field about what is or isn't a certain disorder. And often symptoms sometimes vary in the different conceptualizations. So you can see that research here, almost 20%, major differences in many, many disorders within. And thinking historically too, let's not just shift it towards modernity, but historically in psychology, we've seen so many explanatory paradigms for mental illness. So thinking about the humors in the body, thinking about demonic possession or other religious influences. And some of these may still be influential today. Behaviorism, this idea that behavior is purely a response to context and learning. Psychoanalysis, the days of Freud and the early kind of starts of therapy. Biological, now we're kind of moving into a cultural era, recognizing the influence of relationships and context and values in people's behavior. So there's disagreement over time and disagreement within the field as it stands, right, both nationally and internationally. So this is painting a picture of disagreement and kind of recognizing also that there is room for growth here, that the current models, the current explanatory paradigms we have may not be all encompassing. And so that's where we're bringing in some of this critique.
I guess if you wanted to encapsulate, summarize all this, I guess this is the problem. If all you have is a hammer, every problem starts to look like a nail. The idea is that there's nothing wrong with the medical paradigm. If that's all you're using for this to explain these different phenomena, then that's reductive. It can be overly simplistic. There's nothing wrong with that paradigm. As Nona also pointed out, there are other options. There are other paradigms that sometimes might be more relevant. That's the contextualist aspect. So what I mean by the overlap with rational existential attitudes is the way that the American Psychological Association, for instance, defines how you can tell if someone is having depression. So no longer taking joy in activities, of contemplation of death and suicide. There are lots of perfectly rational. Those could indicate depression, but they could indicate lots of other things. So the person, for instance, who sets himself on fire to protest the Vietnam War, for instance, that's a perfectly rational attitude one might take, right? if I sacrifice myself, I will draw attention to this issue and that might resolve it. It can be very rational. So Foucault, and for the sake of time, I think I'm just going to note this as his emphasis on medicine as a regime of truth shaping subjectivity. What do we mean by that? The idea is that, as Nona pointed out, medicine, like everything else, goes through these paradigm shifts, and it's the view of kind of medicine is, or science in general, is adding more facts, and we're just getting better and better and better all the time. Thomas Kuhn, maybe hearing reflections, echoes of Thomas Kuhn here, isn't how things kind of catch up. Oftentimes there's one paradigm just replaced by another paradigm, and maybe things are improving in the way that our care is effective, but oftentimes you're just choosing one set of explanations for a different one. And you can sometimes have those paradigms side by side. So all that is to say, the medical paradigm is effective, and we're not criticizing its efficacy, or maybe we're questioning its universality. So the third critique is we're critiquing medical paternalism. And I apologize for this image. I kind of, but I liked it so much, I just couldn't get rid of it. It's a little silly, but it really perfectly encapsulates medical paternalism, which is the physician's assumption that the patient's illness renders him or her incapable of clear judgment, and that the physician's medical judgment alone should determine the course of care. And this does not mean that, so there are obviously cases in which this should exactly happen, in which case a person is mentally incapacitated. So for instance, if like a child is found by the side of the road, a young child, and there's no guardian or legal representative there, the doctor will have to make decisions on that child's behalf. That's not medical paternalism. That's just due diligence. Medical paternalism is when someone does have rational capacity and the doctor ignores that for some reason. So some of the support for not for medical paternalism, but for a doctor ignoring presumed autonomy or decisional capacity is the fact that most suicide attempts do reflect transitory state. In other words, the vast majority of people who commit or attempt suicide, who show up in these situations, do go on to live happy lives. It could be presumed that most attempts are caused by like emotional distress. And here's where we get back to this idea of it's not in line with their value system, right? So it's very much appropriate for doctors to oftentimes assume this. However, we have to make a distinction between the acutely and the chronically suicidal. So medical, the principle of beneficence overrides autonomy, because in most cases of suicidal attempts or ideation, the suicide is acute. It's temporary. It's especially transient. So it reflects an ambivalence about the doctor may have about the patient's ability to decide. You know, if the person in their care is having an acute emotional distress, they might not be able to make a rational decision about, well, what's in my value system? Is my life worth it? The patient has a low degree of decisional capacity, and because of this, the emphasis on the principle of beneficence over autonomy. And because of this, the doctor is going to enact aggressive measures to protect the well-being of the patient. However, in cases of chronically suicidal, what does that mean to be chronically suicidal? Well, it means that it's closer to what someone might articulate as their value system. You know, maybe decades across their life, they consider that maybe their life isn't worth living. We see this oftentimes in like terminally ill patients, people who know that the next 10 years of their life are going to be filled with interminable and intractable suffering. And so oftentimes in these cases, there's a high degree of decisional capacity. There's no kind of acute episode. It's just a general reflection upon the value of one's life and one's ability to expect intractable and ongoing pain. There's an emphasis on the principle of autonomy because, again, there's nothing acutely disruptive of one's ability to grasp and decide. And because of this, there's a greater focus on, there can be, a greater focus on facilitating patients' assumption of responsibility for their own actions. So there's greater room for patients to decide whether or not they want to continue their lives. Another helpful distinction here is between withdrawal versus withholding. The difference between withdrawal and withholding is no one is advocating, we're certainly not advocating if someone comes into a medical setting having just attempted suicide, one should withhold treatment. No one has advocated that. What's ethically defensible on a contextualist model? Care should not be withheld, the patient should be stabilized. But at some point after the patient has been stabilized, perhaps whether or not they're in a vegetative state or not, let's say they're on some type of life support or life supporting technology, then we can ask, can we withdraw the treatment? So for instance, if a person has come in with a suicide attempt, you stabilize them, but then now they have DNR, they have is this attempt in line with their value system? We can talk to friends and family, you can get a bigger picture. And at that point, it might be ethically justifiable to withdraw treatment. So an important distinction of what this would look like practically on the ground. And then the last critique we're making is between psychological versus physical pain. So for the sake of time, we can't get into all the distinctions about, for instance, Scandinavia versus Oregon versus the United States. There's a lot of distinctions here. But in general, where legal suicide is legal, it is usually legal in cases of terminal illness and or intractable pain. What I mean by intractable pain is the expectation that one can expect to undergo a lot of pain for the remainder of one's life. So oftentimes, again, in people who are terminally ill. So the idea is that the philosophical justification for this is that one judges that the remainder of one's life is not worth living. This is a widely accepted, although not universally accepted, justification for some type of suicide. In cases of psychological pain, that's not currently accepted as a justification. And this is a bit exploratory. This is not a well-developed part of the argument so far. I'm kind of curious in Q&A, so what are your thoughts about this? But the idea is that we're questioning whether that's philosophically defensible. What is qualitatively different about psychological versus physical pain, such that only the former, physical pain, is justifiable, provide justification for assisted suicide?
So a couple main points we want to really hammer home here is this idea of whether suicidal ideation can ever be epistemically rational. Right? We walk through some different scenarios here and start to get more complicated, right? If you think about someone having an acute episode, well, maybe no, not at all. They're not. They're incapacitated, they're overwhelmed. Maybe this is a one-time thing, a perfect storm of something happening in someone's life. But then we complicate the situation, right? What if it is a rational decision over time? What if it's chronic? What if the remainder of one's life is deemed to be a certain way? What if it is a rational portrayal of the reality of the situation? What if it is in line with your values? And we think about that case when we think about chronic illness, right? And there's incredible controversy in the United States even about whether or not this should be allowed. If a patient has terminal cancer, should they be allowed to end their life, right? And they're very strict regulations. Other countries may have different approaches to this. So that almost seems morally easier to take on. But then that kind of psychological pain, that distinction, I think is so central here. So we welcome your feedback, we welcome your thoughts, because even for me operating from a health perspective, working in a hospital, this is controversial for me. This is even difficult to think about because we are taught that beneficence is the most important value in our work. We're taught that safety is the most important value. So thinking about some of these kind of contradictions and tensions here in this argument. So maybe this idea resonates too, that suicidal ideation is not always pathological or irrational, right? There's a basis for this in the philosophical literature. And respect for agency requires contextual assessment and epistemic care. So this isn't just a quick decision made by a physician, but this might require a deeper evaluation of a person's motivation and context. And this idea of libertarian contextualism, which upholds autonomy while also safeguarding life. So can we find a balance between these different principles? And that's part of the discussion we want to have with all of you.
So one of the outcomes of this, if this was contextual libertarian perspective taken seriously, is kind of a different model of clinicians as not just people who, again, going back to deontological kind of application of rules, but as interpretive agents. What we mean by that is people who can literally read the situation and change what they do accordingly. And of course, they already do to some extent to be good at their job, but more flexibility, more ability to use different paradigms, more paradigms. And a greater need for philosophical literacy and end-of-life ethics. So again, some clinicians have been critiqued for being too literal sometimes in the interpretation of moral rules and the way they apply those, too straitjacketed. So we recommend kind of a greater literacy in some of these difficulties and messiness. Philosophers love messiness, right? For good or for ill. In this context, we think it might be a little better to emphasize the messiness, contextualism.
I will say psychologists hate messiness, and we like rules in healthcare. So there is some disciplinary tension here.
Exactly. And so we also want to balance, though, between universalist principles and hermeneutic sensitivity. The rules are important, right? In a healthcare setting, you can make decisions very quickly, and we don't all have the luxury of sitting and contemplating the deeper issues all the time, right? Like there's this tension, right? There have to be rules, but there also have to be flexibility about them. And again, highlighting this tension between, on the one hand, beneficence, but also autonomy is a principle of medical ethics too. It's one of the four main principles. But we also are advocating for maybe a greater place for authenticity. And I think the Stoics don't really have a well-developed concept of that. But I think it's there, and especially for the existentialists, being true to oneself and one's own, being able to make decisions about what your value, the value of your own life is, and the shape that you want it to take, and also what a good death looks like for you. It's not a universal definition of what good death looks like. Thank you very much for your time.
Okay. And I wonder if we have lots of people online as well. Are you going to let's wait if there are questions? Yes. Okay. Yeah.
Thank you so much. It's very interesting presentation and an overall very sympathetic project of not completely rationalizing suicide. So my question is about what you said about pain at the very end, like when you said that it's only physical pain that is considered as kind of justifying suicide, and you were wondering why not the mental pain. But I would like to ask, is it really only pain that can justify suicide? I mean, I'm just wondering about the cases where the person is just going to lose all their ability to move or do something, but they're not going to be in pain. So has anybody tried to justify suicide on some other basis than the basis that your life will be just suffering?
You take that if you want.
You could just that I'll take the benefit, please.
Yeah, I mean, it gets very complicated very quickly, of course, talking about the different, just the distinctions between even within the U.S., like it's legal in Oregon, for instance, under certain circumstances, it's not in most other states, and that's not even talking about other countries. Generally, pain, and I'm happy to be corrected about this. I'm sure no one knows much more about this. Generally, pain, in my understanding, has been the predominant justification, but I think it's more of a holistic kind of quality of life question. So, like, if someone's, and pain is just generally held to be the main marker of that. But yes, I think incapacity is also often taken as well. Impact of like burden, even economic burden, if someone is going to require very expensive care that's going to financially ruin their family. Generally, there's more, at least in the US, where it's a lot of more holistic picture is taken. But in terms of kind of the main and easiest way to justify or get that approved is being able to have a doctor say that you are, like, if you have been diagnosed with cancer, this is going to have the rest of your life is going to be characterized by intense physical suffering. So no, not the only marker, but in my understanding, usually the easiest to justify euthanasia. And that's more, euthanasia cases, and sometimes assisted suicide, but yeah.
Yeah, I think there is an element of, to your point, kind of functional impairment. So what we call ADLs, medicine activities of daily living. Are you able to function in the way that you would like to? How impaired are you in different domains? But that's not necessarily just specific to this case, right? You could be paralyzed, for example, and have really impaired ADLs. Maybe you're not in pain, but you're not able to function. Your quality of life has decreased. And so that's also a complicating factor. But yeah, in the US, we have very different approaches, and it's a very controversial argument versus some other, even like European countries, have different approaches to this idea of autonomy and what cases are permissible or not permissible.
Thank you. You have a follow-up? Any follow-ups on this one or a new question?
I have heard of the cases where in Europe too, you can get recognized when you're in a wheelchair or paralyzed from up here, and you just really can't do anything with your life, or for example, you have been a dancer and now it's just depressing to not move at all. So that can pass as a reason to.
Yeah, what we're trying to highlight is not necessarily like acute physical pain per se, but it's still an emphasis on the physical. It's if someone is, paralyzed, for instance, or undergoing, it is still kind of a downgrade. Who in Europe, my understanding is that it's very hard, it's not possible to justify euthanasia purely on the basis of psychological pain. Usually needs to be psychological pain as caused by some type of terminal illness or paralysis. If I'm happy to be corrected about that. So we're just highlighting the different valuations of physical versus psychological, which we're questioning the philosophical defensibility of.
Yeah. Do they even make this distinction, physical, psychological pain nowadays? Isn't this a controversial issue whether you can actually?
Yeah, there's been some very recent, and that's kind of been the scope. I didn't invent this criticism, right? This physical pain is has on firmer ground. A lot of philosophers are now arguing that we should also value psychological pain as a marker, but it's very much so. A lot more work to be done. That's generally not. It's still an uphill battle to argue for that.
Very psychological component, but
Anyway,
I'm going back to the list. No, I'm back to and I'm going back to my list now. Yeah. Okay, then.
First of all, thank you both for your talk, very interesting. I may have missed something, but it's not clear to me when with the suicide can you're Russian or Russian. If you could make a couple of examples.
Sure. So I'm thinking of, and I guess Nietzsche, love him or hate him, does provide a pretty helpful view, I think, of what a collective good death looks like. So I think, one of the important things is it's in line with your value system. What does that mean? Well, let's take someone who, for maybe 20 years has articulated that maybe they don't think their life is worth living. Let's say they can point to things in their life that would make their life less than wonderful. Let's say all their family has died and they're living in poverty, and maybe they're a minoritized population that, well, I think it's quite tricky, but I'm thinking more oppression. I think someone who feels very oppressed in society or is going through a lot of suffering, and has articulated that they don't feel that their life is worth living for a long period of time. So this is chronic suicide, for instance, or someone who has articulated more practically, someone, for instance, who has articulated friends and family that, I hope I'm never put in a vegetative state. So that's something that people often articulate to their friends in a casual way, like, I hope I don't want to be in this state, or maybe in a formal level, they have some type of end of life documentation that says how they would like to be treated in their life. So I don't want to be put on life support, for instance, or do not resuscitate me if under these conditions. So it's a picture, right? It's a picture of someone who has said that under certain conditions, my life would not be worth living. They're now under those conditions. So it would be justifiable in that sense. Yeah, I mean, I would think one could make the case that there's nothing inherently irrational about judging that under these conditions, because the assumption is, I think, that life. The argument that a lot of these philosophers are going to make is that it's irrational to assume that your life is always intrinsically worth living under any circumstance. And if you agree that life can become not worth living under some circumstances, it's just a matter of reasoning under which circumstances is life not worth living. So there's nothing irrational about that. You can disagree with, the calculus, but there's nothing intrinsically irrational about that calculation. So the argument goes.
Yep.
I agree with the basic assumption, but I have a concern, and I'm coming from political science background, so please ignore my comment if it doesn't fit neatly into your discipline. My concern is that thinking along the lines of if a person is already marginalized, already having a miserable life, then let's give them an option to kill themselves. Instead of thinking, how can we make a condition where this person is not miserable to start with? But then on the other hand, we in the case when it would be rational to kind of opt for assisted suicide. For instance, there is a YouTube channel that posts about people in different interesting and hard life conditions. And there was this particular interview with a person who was abused by their father in a very young age. And then this kind of damaged their mental health, basically, and eventually this person killed themselves. And this is kind of an example where after years of therapy, this person just simply found it unbearable. So maybe this tension of the social conditions and yes, the mental health.
Yeah, I'll take that first. I think you absolutely raise a great point, and in psychology, we also value the same things. Like we need the societal change. Like it's not to say that it is okay that people may want to do this. We're not saying the burden is on the individual. The burden is absolutely also on the society to change and recognize inequity, recognize systematic oppression. The kind of interesting piece here then is that should we take away people's autonomy within that system? Yes, we need structural change, but in addition, should we take that choice away from a person? And that's the interesting piece here. And I bring the psychological piece to it in that I think often people make irrational decisions about suicide. I think often I work with a younger population and what even feels like it's chronic, a couple years, we've all had turbulent adolescence, right? I don't think any of us are exactly the same person we were as a child. People think things may last forever. They think that certain conditions of their life may continue on, right? We also know that's not the case. So what may feel morally kind of rational at this point may also change once you have grown up, once you're in a different setting, once you're getting psychological services or something else has changed in your life. So that's where I struggle with this argument too. And I actually welcome anyone's input on what that looks like. If we can ever make a really accurate assessment about what forever will be, if that is morally rational or irrational. But I appreciate your comment too about the systemic factors, because I think that's incredibly important here. Anything to add?
Yeah, I think that's a great answer. I covered almost everything I would say. The only thing I want to add is that if you're interested in, this tracks really closely with another issue in bioethics, which is the monetization of organ donation. So some people, for instance, will advocate for being able to sell your organs or blood or plasma or whatever for money because it's your body. I'm selling my body for labor right now. I'm monetizing my brain, and we do this with every whether it's a sex worker, an academic, or a manual labor, we're all selling our bodies for money. So what's the difference between that and selling like little parts of your body? Some will argue there's not. But who is most likely to sell blood and plasma? The people who are most marginalized already. So right, there's exactly this kind of can we address the societal impacts which would encourage someone in a desperate need of money to sell their body for this reason, while also respecting autonomy. And it's really a difficult, almost intractable problem. I'm just mentioning this because if you're curious, there's a lot more discussion of this in that context than in this context. And also, there's probably no easy answer. So I'm happy if anyone has any recommendations, because that's a really great question. Really putting your finger on the thumb on it.
Yeah, thank you. Thank you very much for the talk. It raised a lot of interesting thoughts for me. I was just thinking about, you made this distinction between rational, irrational, and acute and chronic.
And I was just thinking whether there could be another to say justified or not justified. Because as you were now also answering to the previous question, it may be that it requires some kind of judgment from the point of view of the doctor, which is actually just like whether this is not only whether it is the belief is of somebody, is it emotional or is it just a belief based? But it's also like whether the situation can be changed, because you started to say that this can go, this may not last forever. There may be some other kind of treatment, not only medical treatment, but the social kind of support can be delivered. Or, I mean, I was just thinking very often with the young people, it is just like I'm in unhappy love, for example. I mean, I have been, I just want to even show to somebody who has left me that to punish him or her or something like this, just like, which is not totally irrational, I would say, but it is from the point of view of the doctor or the psychiatrist, perhaps something must have said like, oh, just child, we will take care of you and just sleep until morning will come and it will be all over. We have all been in this situation, things like this. Not thinking about these medical situations, but rather about the life situation. And I'm very sympathetic with your saying that this context matters a lot. That you have to think: is it actually in accordance to the value system of the person? But this seems to me to be just one dimension. I'm very sympathetic with this. And I think it is valuable, and also in the case that somebody still now discussed about advanced directives, for example, where you also as a psychiatrist have to say whether this kind of should it start to resuscitate or not. Has it been written down that the person doesn't want to be helped or something? But on the other hand, this is just like, it seems to be like one dimension. And then the question is some kind of paternalism, weak paternalism, allowed for a psychiatrist? If it is, then there should be this dimension also justified, not just. So what do you think about it?
Yeah, I can take this first and you can jump in. And that's, you articulated the concern I have with this argument, because I do think some degree of that may be warranted. But I'm trying to conceptualize perhaps what concretely that looks like. So I often work in hospital settings where I'm doing evaluations for things like transplants or organ donations, right? We have a process in place to evaluate if someone is of sound kind of rational decision making, at least within the medical context, and if they can go forward with a procedure or a major decision like that. And so I think some maybe degree of oversight would be helpful and very beneficial within that context of making this distinction, or having to go through certain steps, maybe proving that you sought care, proving that you've made this decision. But I'm also coming from a very different perspective. I struggle a lot with this argument because I'm taught from day one that I must ensure the safety of others. And I've had to Baker Act children and adolescents, and it's been one of the hardest decisions of my professional career, because it is no light thing taking away someone's autonomy. It's an incredibly difficult and debilitating decision. So I'm open to kind of feedback, but I also take maybe a light paternalistic approach, and that maybe there are situations in which it is justified, and maybe there's also some degree of oversight that's necessary, especially in the case of children. We're making it much more complicated because children also don't have the same legal autonomy in general with any decision, right? Medically, parents can make decisions for children under 18, at least in America. So that also takes away another level of autonomy here. And that's not talking about suicide, that's anything. That could be seeking treatment for a procedure, surgery, or even taking medication. But I'm curious, what do you think, Dylan?
Yeah, there's lots of different directions to go with this. You give me a lot to think about. I like this idea of justification. I've kind of been thinking about it since you brought it up. And I think you could also distinguish between justified for the doctor and justified for the patient. And you might come up with very different responses, right? And then I kind of rabbit trail thinking, like, what does it mean for even the individual to be justified? And so basically what we've given is is a very kind of individualistic, and I don't know if this doesn't get too far away from the spirit of the question, but I was thinking about the individual justification. This is basically, if you want to oversimplify this, this is to be an argument for the individual patient's justification. There's a sense in which they don't have to justify it, right? It's their life. If they decide their life is not worth living, they should be able to, and so they provide a justification. But you can complicate that further and say, well, what about the impact that it's not just about you, right? Your life is not just your own. So there's a sense in which you have to also justify your choice to all the people with whom you're connected. So, and I think it gets a lot murkier too. And so like maybe, so I'm kind of going this back and forth, even what it would mean to justify this at an individual level. But I like this idea also, yeah, the doctor has to justify this on a not only moral sense, but a legal sense too, right? And we have to think about like practically what this would look like in terms of being sued by the family, for instance, for living wrong choice. And a lot of this model has received a lot of pushback from physicians for like, we should be expected to do all this, right? We're just trying to do our job and apply these rules, with some flexibility, but, this needs to happen at the procedural level, institutional level. It's not something you should expect doctors to have to justify every time. So I'm quite sympathetic also to some of the pushback. I don't want to go too far aggressive in your question, but it's
Actually, so let's get your president.
Thank you. Thank you for the talk. I just had a question about, okay, so we are going to judge suicidal thoughts based on rationality. So my question is, how objective or how subjective can we get here? Because, so I can, for example, I can think of two scenarios. Someone in PDS that is objectively all the reasons to want to end her life. And then we have someone who is depressed, and yes, it is still objectively a bit painful, but it can be kind of helped. And then we have someone who has lost everything in life and see absolutely no hope in living their life and just want to die. So I was thinking, is the last one as valid as the other ones? Or just because we objectively see that, okay, this person has lost everything, maybe they should find hope. It's not the end of the world, but we are just disregarding their own point of view. Is it as valid as the other option? Or
yeah, I mean, the argument is basically that there's no, it's not, or I'm doing a kind of this philosophical maneuver when you're scared to take a position. So you say, if you believe X, you should also believe Y. So we haven't been arguing that, for instance, assisted suicide should be legal in cases of psychological pain. Our argument has been that if you accept that intractable or foreseeable long-term physical suffering is a justification, then you should also accept that psychological suffering should do so as justification. So yeah, between the two and the second and the third, we're arguing that there is no real distinction to be made in terms of legal justification, and that's more of a legal versus an ethical argument, I suppose. But yeah, that's basically the argument, is that there's no intrinsically, like qualitatively interesting philosophical distinction between scenario B and C.
I'm not sure if that's a question at this point because it's more of like a follow-up on everything that has been said. But I was thinking about the situation of military actions or political repressions, also in the sense of if a person commits suicide while being imprisoned and while being opposition activist, for example, and it's not the pain, maybe not the physical pain, but it's more of like the values that they have. So it's more of like an act against the system. So it's also, or if a person who has been involved in the military actions is being in captivity by another authorities. So it also might not be about the physical pain, but it's like a completely different category of like beliefs and values. So it might also need to be categorized in some sort of way, considering the context of the situation. I'm not sure if it's probably not a question because you've already mentioned that there are different options and different approaches.
But yeah, just thought about this as a very contextual situation in which a lot of things are changing, or as you mentioned, well, Kristen was here, mentioned that if a person has lost their whole family to war, for example, and they no longer see a way to leave, it's also a very particular situation, but I think it's kind of like in the age where we live right now, kind of could be also taken into account.
Yeah, I think it's a great point. And I think it just adds another kind of layer to and humanizes some of the conversations we've been having. Because that was something we were thinking about conceptually when we were walking through this argument. It's one thing thinking about a child, you know, upset after a breakout, trying to kill themselves, landing in the hospital. And it's another thing to think of a political martyr or someone captured, you know, during some kind of war who's standing up for a cause or recognizes that their future is no longer livable or that they're going to be met with immense suffering. And so it's an interesting kind of thought experience to maybe find something in the middle to figure out which situations feel more defensible and which do not, and what the kind of degree of autonomy there is as it shifts depending on the context. So a really great question too.
Yeah, you're right. We kind of were actually going back and forth on this book this morning before the talk about the distinctions and like which examples we want to use. And yeah, I think I can only speak for myself. I do think there's a interesting distinction between, for instance, like the political or religious martyr, and maybe the person who we've been discussing in more detail. I guess the difference being that the martyr, for instance, could say, "My life is worth living, but I'm willing to sacrifice it for some greater good." Versus the person, I think, a little bit more under the magnifying glass here, who says, "No, my life is not worth living." So I do think it's a philosophically interesting distinction because we tend to think that the former person is epistemically rational, whereas we tend to think that the latter person is not. So there, we've been trying to argue that the latter person is epistemically rational or can be, because usually, like I said, the martyr is all we already assume they are. But that's an interesting. I do think the reason for which one would commit suicide has vastly different, like philosophical justifications or lack thereof. So I'm glad you brought that up.
Thank you very much for the presentation. My question is about decision capacity. As you mentioned, in the US and most part of the world, until 18, people do not have the right to make certain decisions, and their parents making decisions for them. But we know that there's a variety of decisional capacity between 0 to 18, and probably the old speaking theory have different levels of decisional capacity as well. Is there a certain threshold regarding measuring the decisional capacity and how it's actually happening? So if it's above that threshold, so it's below that, we keep person hospitalized. My question.
Yeah, I think it's a great question. I can speak to, so in some of the pediatric care, for example, at a certain age, I think it tends to be around 14, like we require informed consent from children, even if they're not making medical decisions or some medical guardian making decisions for them. But we still require them to also assent to the procedure. So they're kind of like levels of change here. After 18, there are procedures in place, but mostly for people that are incapacitated in the sense of having severe developmental disability or this idea of being a risk to themselves or to others. In that case, we take away that decision making, but it's really only for those extreme cases. So mostly, no, we would assume that someone can make a decision on their own unless they are severely impaired in some way. And that's the kind of the gray area here is what qualifies as severe impairment. Maybe we can agree if someone's not health literate and they can't read and they have kind of mental capacity as someone much younger, then maybe they shouldn't be making decisions as an adult. But then what about this idea of risk or harm or the contemplation that we brought up within this PowerPoint? That could be a little bit different. So it's a great kind of question, and also really depends depending on context and state too, probably even internationally, that there are different ways of conceptualizing autonomy. And for different procedures or interventions, we actually assess that differently. So what it might look like to do a risk assessment is very different than doing an assessment before a surgery, very different than doing another kind of assessment in a medical setting. So it does also vary depending on that.
Yeah, I just want to add a different, that's really, really helpful. I think there's also like an element of, we were talking about the difference between acute and chronic as justifications. And it's question, and also the importance that one's decision about one's care is in line with one's established value system, which is usually something you can only tell with enough time. And the problem is that even like if someone's 18 or 19, have they had time to be chronically depressed, for instance, or have they had time to develop a life system such that they are able to, their decisions can be in line with that. I mean, we have to be careful not to, again, be paternalistic. I think it's a question to ask whether someone like, for instance, who's 18, I think it would, if I was a clinician, it would encourage me to think of that as acute rather than chronic, right? Like, is it even possible to have chronic? I mean, I'm overgeneralizing, but you understand the point, which the time dimension is important, right? And that's why generally it's much harder for instance, younger people to get even, and for physician-assisted suicide, it's much harder for younger people than older people. You get a bit more of an uphill battle because the time dimension, save a life's view, enters the picture. Would you say that's accurate?
Mm-hmm.
So now before we start seeking about questions by those who have asked one question, can I give a quick comment about the Stoics first? Because I was wondering, like the Stoics, right? They think, yeah, the only virtue is good, only vice is bad, all the external things are indifferent, don't matter. But one wonders with the suicide, this be an indication that maybe those external things don't matter really enough for you to kill yourself. Do you think there is any danger here, or would you?
That's a great question, and I'm curious to see if you have answers as well. But I'm really jazzed about Stoics. Want to answer that? I love it. I teach in my class all the time. I can only say what my view is that for the Stoics, they are truly indifferent in the sense they have no moral value one way or the other. It's just insofar as they make it harder or easier. So I still think the Stoics are pretty generally against suicide as in terms of like what it indicates about you, because I think some of them believe quite strongly is no matter your circumstances, you should be able to be virtuous. But I think they also recognize that practically speaking, it is extremely hard to be virtuous the worse your conditions get. So I think for them, the indifferents are indifferent, but they also want to be human about it and recognize that most people, most of the time, undergoing constant pain, being oppressed, being like all these things are going to make it harder and harder. So like, how can it makes the virtues like beneficence benevolence or like giving money to others. If you don't have money to give, for a lot of Stoics, like as for most of the ancients, like, for Aristotle, that's or friendliness. You can't be friendly if you don't have friends. And sometimes that's beyond your control, right? So can you be virtuous? Yes, but the realm of the effect becomes much, much smaller. So, and I think their emphasis seems to be like, Epictetus' open door policy, right? This idea that, he says his example is you go to a friend's house, they start cooking, they close all the doors, it starts to smoke, it starts to get worse and worse and worse. And you're trying to have a conversation and trying to exist, but your eyes start watering, you start choking, but you just sit there and continue hanging out with this person. Epictetus says, look, the door is open. You can leave anytime you want. But if you're not going to leave, be happy where you are. Like, accept the situation, right? Like, so it's the same thing with life, right? Like, life might suck, but don't sit there and complain about it and moan as type something. You can leave at any time. So if you stay there, you're saying that like it's worth it under those conditions. So for me, the emphasis is more on like, if you are going to stay, what should be the attitude towards life? But that's my take. I'm curious to know if anyone else has different views. I'm not.
I think what they say, just the death is indifferent. So you didn't, can't take the too serious either. but okay. Questions online? No? Okay. Then, yeah, I was wondering. I don't know the Stoics. Yeah.
It just follows like naturally after this. So I mean, I was wondering about the Stoics as well, that you brought them up as kind of philosophers who justify suicide, and that you emphasize that it's important to be virtuous and it's not important, your biological life is like not that important. So I mean, I guess that the Stoics have of course said many different things, but one thing that they also say, there's this famous example, the Stoics also say that you can have a good life even when you are on the torturing. Right. So, and because what matters, your virtue, and you can still be virtuous. How you react is kind of still to some extent up to you. And of course, this is a more extreme example of a Stoic doctrine. But I'm just wondering, how does that fit in with these scenarios, like where, like, in most of these suicide cases, yeah, we discuss these cases where people are like suffering. So these do not seem to be the cases where the Stoics would first and foremost say that, oh, since you are suffering because of the externals, you should kill yourself. But yeah, it seems to me that at least many Stoics would say that you should stay firm, you cultivate your virtue, and you don't let yourself be disturbed by the pain, or at least this is how it is often depicted. The Stoics have said a lot of things. I mean, how exactly do the Stoics like fit in, or is it just like as you earlier said that? But yeah, in practice, it's going to be hard to be virtuous. But yeah, I'm just wondering, thinking about the example of living a happy life on the torture tree, which does not seem to be in favor of suicide or giving up yourself.
Yeah. I think it's a great question, and I think there's a tension with within the Stoics, and sometimes, for instance, Seneca, who famously killed himself, has a different under constrained circumstances, but has a different take than Epictetus, for instance. The way I view it, and again, if I summarizing the Stoics is not always easy, right? I mean, they're not really oftentimes offering a systematic, the Enchiridion is not a systematic philosophical treatise, but I do think you can generally make a distinction between like the ideal and the real. So I think for the Stoics, because one's virtue is the only thing that has actual value, right? It's the only thing that has, in the sense of like morally good, right? Like a shark eating a fish is not morally good or bad. An earthquake killing a bunch of people is not inherently good or bad. It's just the way the universe works, right? So once you say that moral virtue is the only thing that's intrinsically good, I think you can make a distinction between like the ideal would be having your virtue no matter the externals, right? That's the ideal. When you're getting flogged, for Epictetus, you have your leg broken and you still say, what about the other one, master, right? Like that's the ideal. But I think they're also savvy enough because they're offering like real life to say, well, but really most people, if you can't attain that, what's the next best thing? And I think for them, the next best thing is if your life can't be, if you are finding it really hard to be virtuous, under those conditions, like if you're not able to be, it's at least understandable. So not the best, but acceptable. So I think right. I think that, would you agree with that distinction between like what a person maybe should do in the best possible situation, and then versus like what practically maybe would be rationally defensible?
I mean, I understand where you're going. I'm not sure if this is like a classic scenario in the suicide cases. Because I'm not sure if they are predominantly to do with pain, then this is probably not the virtuous motivation.
I think I know. Sorry.
Wilder idea that you're trying to defend that in reality, that you won't be able to stand the pain and your virtue will suffer.
I take your point. Yeah. So let me make it a further distinction. I brought the Stoics more to argue about the epistemic rationality, and for them, after the Stoics, I do think there's an element in which it is rational. So that's why I said open door policy. It's kind of like it is reasonable for you to leave. You need to. It's not that it's preferred. It's not that it's ideal, but it makes a certain sense. I cannot become because I'm weak-willed, whatever. I cannot actualize ataraxia. Thus, my life is not going to be worth living. Thus, I should exit. It's not ideal, but it makes a certain rational sense. I take your point that so I think that point stands with them. I do agree with you that they would not agree probably that like suffering is a justification ultimately. And so that's why I brought in the existential. So I'm doing a little bit of, I think different traditions emphasize different. So like Nietzsche and Camus, I think are much more apt to, less apt to emphasize that it's rational and more to emphasize that suffering is a reason. Or, so yeah, I take your point. I don't think the Stoics are the best example for the type of case in the sense of using suffering as justification. But I do think they have something to say about it not being intrinsically irrational to consider. Even a lot of the other ancients would agree with that as well, like the Epicureans. I think Aristotle also has some interesting lines about it being justifiable, maybe not preferable, but epistemically justifiable, rational. But I would invite pushback on that. Maybe, maybe it's a misread. Yeah.
Follow up on this, or new question. Then we go back to our list.
Yeah.
Hi, thank you for the interesting topic. I wanted to ask, I don't even know if it's more of a question or like a discussion, if you have considered the cycle chain thing, like when a person actually doesn't have any pain medically, but is still hurting. Like the pain is real, but it has no medical, like it only has the psychological factors. For example, a lot of it has to do with, for example, anxiety or things like that. Then the difference between mental and physical pain is really not there anymore, because the person actually is feeling it physically, but she can't there's no way to show it medically that they are actually in pain. So have you considered that when you have been thinking about the pain of physical versus mental?
Yeah, I'll take that first. I think it's a great way to make this distinction more complex, because you're absolutely right. And I think it might have been your point earlier, there's actually not a lot of distinction scientifically now between the physical and the emotional kind of pain, in the sense that all pain is cognitively mediated, it's all psychological. So interesting research has come out showing that our psychological interpretation of pain actually affects the physical experience of it. It's a very integrated process in the body. So it's a false dichotomy to create kind of emotional and physical pain. Even when we experience, for example, social rejection, this is one of my favorite findings in psychology, it activates the same neural pathways involved in physical pain. So when we're left out of a group, we're being ostracized, your friends are talking behind your back and pointing at you, that actually creates physical pain in the body, or a very close approximation to it. When you have a heartbreak, that's not just an emotional term, it's actually a physical reaction you have. So interestingly, we're breaking that down now, and I do think it's a very valuable point. I think the medical model and the legality still falls on the medical conceptualization for legally kind of promoting suicide, or allowing suicide rather. So you need a medical basis, you need to be paralyzed, you need to have a chronic illness. There must be some component there, and they don't really allow for the emotional without the physical piece. But I do agree that there's a lot of complexity, and I think this conversation should be had in a lot of medical spaces, because we are drawing a false dichotomy.
And there's also like mental health conditions where patient feels pain, like just pain, emotional pain, feels it physically. For example, like borderline personality disorder, they feel pain physically, but it's all mental, and they can't justify killing themselves because there is no physical evidence of the pain.
Mm-hmm. Yeah, there are even chronic health symptoms that are kind of similar, in that they can't find a physical basis, but people experience really debilitating physical pain as a side effect, right? And then it's this interesting question of how you address that. And so I think there's so much complexity here within that. And it's absolutely right to say, and science supports this, contemporary neuroscience, that there is not a clear distinction between emotional and physical pain, but the legality does not reflect that kind of update to the field.
Yeah, of course. I have just a clarificatory question, I guess. I was hoping I would make sense of the question earlier, but I'm still struggling. So how do you talk about a lot about rationality, but and you've given a lot of examples where something is rational, but I guess a lot of our intuitions can be different, and I'm wondering whether there's something more to it than just like being able to give reasons. Is it something to do with coherence with your worldview? Is there something else? So how do you define rationality?
Yeah, that's a great question. And if I was down, I was down here. I am woefully underprepared as an epistemologist. I'm woefully unprepared to give an adequate answer for that. I mean, I would say first and foremost in this context, I hesitate because it depends on, I guess, what we mean. Like you can define rationality in different ways. So I want to focus on like maybe this context would be like the giving of reasons, right? One for one's actions. So for instance, being able to articulate that life is not worth living for all of these reasons, that would indicate rationality. With certain parameters, like the reason I keep emphasizing in line with the stable life view is because if you have said for 80 years that I never want to be, I don't know, I want my death to look like this, and then at the very end of your life, you get into those conditions and you change your view, that would be irrational because it's out of line with your life, your stated life view, potentially, not necessarily, but potentially. So yeah, some type of reasoned reflection on what counts for life worth living that's not constrained by emotion or, and of course, our reason is never disconnected from emotional, psychological, situational factors. But usually in medical context, I think the understanding is that taking all those things into consideration and being able to understand different options. So if I do X, all these effects will happen. If I do Y, all these other things will happen. That's generally how decisional capacity is articulated. If the doctor is talking to you and he says, I'm going to do this, and sometimes being able to get the patient to say back to them, like, what consequences will accrue from this versus other options. That's one way of establishing rationality in this context. But I sense a thought, since that's not a fully satisfying answer.
Yeah, I guess it is, it's a good answer.
Building off your question, I have a similar question too, in that contemplating this from the kind of medical psychological piece is like what justifications would be. You can have many justifications. What is rational or irrational? So is the example we've been talking about of the teenager who breaks up with, their partner, that's a reason, but is that an appropriate reason or not? And then the kind of temporal comes in as well. So what is appropriate? Is it the fact that your circumstances will never change? But then also, how do we assess change, which we talked about earlier? So that's the piece that I still struggle with in this argument, I think, is the definition, because that is almost paternalistic in a way to say this is approved and this isn't. In the medical context, is often permanent kind of suffering. You're paralyzed, you will never walk again. Or you have a chronic illness, you will not recover. So this kind of sense of addressing the temporal. But in psychological pain, that can also be more difficult to assess, to find a concrete answer. So I think it's a really astute question.
Relatedly, at points you talked about specifically about the epistemic rationality, and was there a reason for using that term, given that, like, I tend to associate epistemic rationality with giving of evidential reasons in particular, whilst like the framing of the talk at times at least that was more about like practical rationality in the sense of what to do. I mean, so the question is what to do, right? It's that's the practical question anyway, but it's like, why exactly epistemic? Was the reason for attaching the epistemic?
But, to be honest, I think there's not I'm putting my cards on the table. I don't know that there's like a super hard and fast philosophical justification for why I use epistemic rather than practical, except that, yeah, I'll just say that maybe there is no one. Maybe I can be convinced that maybe practical is better than. I can think of like a potential reason, but that would why one would prefer epistemic versus practical reasoning. I think because maybe we're talking about I think when we use the language of decisional capacity, it's, I don't know how in the weeds it is, but I think it's basically a question of reliabilism versus responsibilism. If you want to get like really in the weeds, the idea being that the question is, do you have the apparatus to responsibly make ethical decisions, rather than do your decisions have good effects, which would be the responsibilist. Like, are you, or sorry, I might have just flip that. Responsibilism. I'm taking that. I view responsibilism as being connected with epistemic rationality. So do you have all the tools in the toolbox for making rational, epistemically virtuous decisions rather than judging from the reliablest lens, which views epistemic rationality in terms of do your decisions tend to get you closer to the truth over time. So yeah, I think that's the justification behind that. I don't know if that's like a hard and fast, we have to describe it that language. I think that's just the logic of what I was using. Yeah.
Can I give a reason for why I think they could be separate?
Yeah.
I mean, you might think that what fame does, it affects your practical rationality, your ability to reason about your own circumstances here and now, whereas it doesn't necessarily affect your epistemic rationality, your ability to give reasons as a whole. You're perfectly able to do that about other issues, but this applying it to yourself, that's what's affected. But at least that's a very Aristotelian distinction as well, right? Practical rationality, it's like reasoning about direction, motive.
I mean, I'm very open to the idea of it being practical rationality, and I think the existentials get quite close, right? When they're especially like for Nietzsche, arguing that basically this is a way that one lives one's life. It's a disposition, but it's also towards one's own life. And I could be convinced by that. I think you could take either track either way, whether it's the responsibilist or reliabilist. Is this tools in your toolbox, or is this just the way one comports oneself towards everyday problems? Yeah, this is more geared towards like the philosophical tradition in the US, which tends analytics. So I think that's why I chose that language. But I don't think there's any a priori reason to one rather than the other.
But okay, Cornelia, thank you so much. I think we managed to cover many questions. If you still have questions, you can still ask. But yeah, thank you.
Thank you all for your time.